Man, thank you so much for taking some time to chat with us. I appreciate your willingness to share your wisdom, your experience, et cetera, et cetera. I think it would be a great place to start by maybe having you give us a little bit about that, a little bit of that background, your experience, that wisdom that we're alerting to. Go for it.
Yeah, no, great. Thanks for the opportunity. Thanks for having me. I have been at a geriatric care management medical practice for the last 11 and a half years. I'm leaving as CEO. I've been CEO the last 6.5 years. We're based out of Minnesota. The company was called Genevive. And I just left that job here in May, but it was a really interesting company. We were the largest facility-based geriatric practice in Minnesota. Majority of our revenue came from value-based care contracts. So I have a lot of experience in value-based care, negotiations, Medicare contracting, dealing with complex patient populations, both on the facility side and in the home-based primary care space. So just fantastic experiences. And, like I said, I'm excited to be here. So thanks.
Awesome. Thanks so much. Well, we'll just dive right in.
Great.
And we'll ask the first question here. So we've spoken to, I would say, quite a few leaders in the risk sort of bearing organization space. I actually remember one CEO telling me that specifically in value, and maybe even just writ large, but specifically in value-based care, like a third of that role, right, that chief executive role is just contracting.
Yeah.
I think she even said, like, she used the term "always be contracting," which I find hilarious. And I'd say your contracting reputation actually precedes you. Someone actually told me Amanda was risk contracting before risk contracting was even a thing. So, given all of that, I'm going to ask the question: like, what's one of the hardest things about contracting to get right, and how have you found ways to mitigate pitfalls in that area?
Oh boy, that's a good one. I think the first hardest thing is getting the deal done, right? Like, what is the shared vision, the milestones, the goals? And it can take as few as a short months and as long as a year or more, 18 months. And it can be really frustrating to set up because you're designing a partnership where everyone wins in the end. And you have to really navigate that. But to be honest, I think after over a decade in value-based care contracting, I think the more challenging thing is maintaining that contract and the contract relationship, because things will change and both sides have to adapt and the inputs change. And I don't really think of marriage as work per se, but it's a little bit like marriage. Dating and marriage, like dating and getting married, takes work. But it's really the long-term commitment that takes the majority of your energy and your time. And so my recommendation, the way I kind of think about that, is never stop putting time into that contract relationship. Even if the other parties change, keep at it. Build a strong foundation of your team, your partnership that can withstand the changes in the future, the changes of the inputs, the outputs, the environment. And so you both are ready to adapt and you know how each other adapt to change. I think that is much harder, is to stay aligned over time.
Wow, that is amazing wisdom. I mean, I'd say that's amazing wisdom just in general, right? In terms of like establishing a relationship and generating enough, I don't know, resiliency there, right? So that you can withstand and adapt, anything that might come your way. Wow,
well said.
That's amazing. Thank you for sharing that.
Yeah.
Anything else? Like any other sort of like common
No,
faults?
that's the big one. That
Okay.
is, in my opinion. I mean, I think, again, the dating portion, the building the infrastructure, right? If you build it on a shaky foundation, you don't have a lot to work with, no matter how much work you're putting into it. But I think that's where kind of the infrastructure and the due diligence and the time you put into it, right? That infrastructure is critical. And I've done a couple of different deals, right? So it might be with a payer where you're trying to understand what's their drivers, where their pain points, how do we understand what they'd like to improve, what's their mission. But it could also be, Genevieve had experience becoming maybe a partial owner in kind of, if you will, a convener of an MSSP, right? And we spent 12 to 15 months working on the operating agreement of how the other owners are going to work together. And I think we're only a year and a half or into that relationship, but the early times are when things start to fall off, right? What's happening? What are we doing here? And building that infrastructure and all the time you put into it is fantastic. But I've built some contracts that just didn't work because there wasn't enough there, or we didn't consider the other party enough, or we built it on the wrong assumptions. And so that part is worthy of time and attention. I'm not saying that, but the long-term relationship, when you build the right thing, which I think the majority of time, because we're so good in healthcare, we do build the right thing. But when you build the right thing, it's the maintenance, full stop.
That's fantastic. I love it. We know Genevieve has flourished under your leadership. And what are some of those measures of flourishing, for lack of a better word? Like, what are some of the performance metrics or improvements that you were able to help accomplish at Genevieve?
Yeah, I think the early years of Genevieve was all about organizing. Think true startup. What goes where, who does what works well, what doesn't work well, this constant process of iterating. And that takes a tremendous amount of thought and time and partnership and investment in people. And the later years of my tenure at Genevieve is all about optimizing. How do we use data intelligently? How do we get data at all? How do we create structures and systems that support our goals? How do we become more efficient as we want to stamp out a new market or a new location? And that is a different set of skills. And so I think it takes finesse and change management. But so the kind of the goals change and the behaviors and the decisions we had to make changed. But one of the things I would say about that, of kind of these key decisions or measures here, was certainly data. We did a lot of cool things at Genevieve, and I did not do them alone, so I'm not taking all this credit. It was always a full team effort. But putting an electronic systems in place helped us tremendously, especially as we transitioned from early stage to later stage. EHR, practice management, data analytics with HIE connections, connecting to other IT systems. And what also happened over my time at Genevieve is, over a decade, the whole world gets smarter at data. And so how do we continue to connect to that and pull out really pertinent data? And so that was huge. That allowed us to create, key performance indicators, OKR scorecards, and sometimes connecting those systems and the technology can be a headache, and it's never perfect. But the more meaningful data you get in, the more you can drive for results.
So that's a great follow-up here. I hear you attributing a lot of that credit to the additional team members that you were able to organize to do all that kind of work. I would imagine that a lot of our risk-bearing audience community is, especially with AI coming in, like they're starting to prioritize how to develop an operationalize data infrastructure or data team. Mm-hmm. Like, how did you organize that at Genevieve, and how did that shake down and what were some ups and downs there?
I mean, yeah, it's a great question. I mean, from going from a kind of I want to say startup, we weren't exactly startup, but early stage to later stage, a more constant deliverable in later stage. You kind of have to do it across the board. You have to do it for your clinical systems. You have to do it for your support systems. You have to do it for your back office. You have to do it for your IT. You have to kind of continue to rethink. I was known for writing org charts and processes on napkins in airports, or, when I'd first wake up, because you were just always thinking about how do we kind of set up this infrastructure to support things. I'll say the biggest learnings, in my opinion, are always the ones you kind of don't get right, and you're going to get right the next time. And every time we'd get a little bit smarter when we put an IT system in place. But the first big IT system that we put in place, I underestimated how much human interaction it would take with that system to make it successful. And so it was like, oh, we need 1 FTE. And in the end, we needed 3 FTEs. And you don't quite know that right when you start. And the way you're setting up your systems and your infrastructure, it makes total sense, and it's going to make you more efficient, and you do get better data. That's the best part, is you need better data to drive for the results that you're getting. But it can take more manpower, understanding that infrastructure. And so those were the early lessons that I learned, that I was like, oh, I didn't really realize how much we still need humans to interact with technology. So
I think people underestimate that even still. So
Yeah,
that's good.
good. I'm not alone then. One of the things that we really thought about optimizing our revenue was because we were a value-based care company, the majority of our revenue came from value-based care. We really needed to diversify our value-based care contracts. And so our ability to expand our market share was dependent on the patient populations mapping appropriately to a value-based care contract. And so those contracts were kind of across the spectrum, PMPMs, quality bonuses, all the way to full global risk, including Part D. But our risk-based ones were by far the most successful. And so when we started truly optimizing our contract holdings, that's when we really started cooking with fire. And that's when we were able to create new markets, go to new locations, get to a scale that we hadn't previously thought about. Even after leaving here in May, that the future for Genevieve becomes so bright because those contracts are set up where the majority of any location we go or any patient population, they'll be able to map to a value-based care contract that will be successful. And so that's really how we thought about expanding, especially in value-based care, is you don't put all your eggs in just one basket. It's about that diversification.
Wow. And I mean, I imagine that just puts more implication or even more sort of gravity or weight on that first question around like get the contract relationships right, because everything flows downstream from there. Wow. That's
And
impressive.
to your point on the person who said that every CEO is at least a third is doing some sort of contracting or value-based care contracting, that responsibility always lied with me as the CEO, because that filtered down into every focus of operations. And it doesn't necessarily have to be this with the CEO, but it has to be with the C-suite and understood by the C-suite very, very clearly, because it touches absolutely every component of every input, every resource in your organization.
This question just kind of zooms out a little bit. Like I know we've spent some great time highlighting how amazing you are, how amazing the work has been at Genevieve. Um, One of the things I love about some of these conversations is just recognizing how experts in their field always have such incredible foresight into where things are headed. Right, to your point earlier, even about contracting patterns becoming the norm, right, that they were 10 years ago. But what do you think, like looking from here, looking forward, what does the future hold for like high needs groups, home-based primary care, et cetera? What needs to change? What needs to keep happening, for groups that are forging ahead in this space?
Well, what's really cool is the future is wide open for high needs groups, home-based primary care. It's one of the reasons I love working in the space so much, because all the answers are already worked out and it's so exciting. And we get to partner together with different groups and different ideas, different groups like Keebler. It's just super fun. I think we will see significant growth and change in the complex care area. So definitely geriatrics, where I was at Genevieve, but it goes beyond that. It goes beyond that primary care. It's behavioral health, dementia, depression, for sure inside behavioral health, oncology, nephrology, cardiology, really a focus on any expensive healthcare areas outside of primary care, I think is where the high needs space will go. And we'll need to think about for value-based care, but also for home-based primary care. And I think those areas will be right for home-based primary care for those patients who are homebound, home limited, complex with few social supports. And I just think that traditional home-based primary care, as we've known it to date, I hate to, it's expensive to operate under fee-for-service alone. And I think even when you work with value-based care, that home-based primary care is going to have to continue to evolve. And we're going to have to continue to figure out how do we lower cost in our infrastructure. I mean, 10 years ago, the goal was if we don't have bricks and mortar, we've lowered the cost. And we lowered the cost on the model. And we still need to think about other alternatives and additions to home-based primary care, right? So we need to think about, telehealth, remote patient monitoring with clear goals, defined goals, community health workers, self-guided supports for patients and caregivers, right? Some amount of autonomy and individuality. And I think the list goes on, but there has to be some stratification of patients based on needs and services that kind of open up, if you will, as the complexity increases. So I know the concept is a little anti-American in some ways, but it's just not everybody has access to the same thing all the time, every day. It
Right.
really is that these supports are there. They kind of open up, as you will, as you need them, as you increase in complexity, or if you have your services and you can decrease in complexity, then you probably have access to fewer supports. And so I think that will be really exciting to see. I think there's a lot of innovation for both those groups, and a lot of need.
Wow. One of the earlier things you said, I kind of got the tingles around this concept of home-based complex care,
Yeah.
right? Or home-based complex care coordination, which is really fascinating, like bringing specialties down across the board. So
And
cool.
I think one of the questions you ask is like, how do we forge ahead? What needs to change? What does that look like? And honestly, I think forging ahead requires us to be nimble. This nimbleness is key. And that's one of those things I enjoyed at Genevieve is, again, in the early days, it was all about iterating and constantly improving. And I think the same thing for this larger landscape at that macro level is more partnership, fewer closed doors, better access to technology and ideas, and leaders who are adaptable and unflappable.
I love that is a line right there. That is so good. That is so good. Oh my
Thanks.
gosh.
Oh, thanks.
Let's close this out with one question that we like to ask all of our members or all of our participants. I'm so grateful you took the time to chat with us. What would be one question that you have for our high needs risk bearing community that listens to us?
Oh, good one. Well, I'll keep it short. I think two things, in my answers, where am I wrong? What did I get wrong? Where's the opportunity for me to learn and grow? And I think, how can I help? Because I think today's new environment requires all leaders to be curious and relentless. And so I have some thoughts, but I think we have to keep asking ourselves, how do we prepare leaders and clinicians for this new environment?
If you had to like give a couple of snippets of how to characterize the new environment, what would you say there?
Well, one of the things that I'm most excited about in the new environment is the new way we're working. And I think the new generations, and especially Gen Z Gen Z that's coming in. I always tell people, every generation that's come before the next generation has thought the next generation was lazy and they didn't want to work, and and it's just part of the tradition of the next generation moving in. And what we find is every generation that's come next has pushed us to innovate, to think differently, to work harder, to work smarter. And I think that's what's happening now is we're working in new environments, and we are adapting to, for the first time, healthcare is being asked to adapt to, what do our customers actually need? Where do they need care? Who needs to be providing the care? And I think our systems in the greater healthcare landscape have been relatively fixed. And I think what's nice about high needs and complex care and home-based primary care is we have this opportunity to kind of continue to be the leaders in innovation in that space, to meet customers first where they are and what they need, and that's super exciting. So I think the environment for healthcare and for our specific space is being pushed really hard, and I think we're responding really well. And we need leaders who can continue to change and be, I think I said it, adaptable, unflappable, exciting, innovative, focus on the future, not get stuck in our ways. We need to think about our people first and our customers first, and we'll succeed. So we're doing great. I think we're doing really well, and there's just going to be more exciting things.
I love it. Thank you so much, man.
Yeah. Thanks for having me.